Good morning, guys. I hope we're all sparkly. It's fair to say that testosterone deficiency is a well-recognised medical condition. There are British Society for Sexual Medicine guidelines, there are European guidelines, there are international guidelines, there are guidelines from across the pond. So why is it so difficult for men to receive the care they so desperately need? Now, the answer to this question is multifactorial, and we could debate the issues all day long. But there are obvious shortcomings in the knowledge base within doctors and the medical profession. Why? We simply do not get taught about testosterone deficiency, and TRT. It is not on our radar. It is not in any curriculum that I've come across. So, medical school, we perhaps had a cursory comment. Testosterone is involved in muscular development and development of secondary sexual characteristics and genitalia, and is important for fertility. That is literally it. There was no further mention of it. Medical school, postgraduate examinations, postgraduate studies, continued professional development. I remember going to an NB Hot Topics course, which is actually really good for GPs. And they said, there's not enough evidence. Boom. Next topic. Let's talk about women's HRT. Let's talk about type 2 diabetes. Let's talk about all these things that the pharmaceutical industry can make a lot of money out of, because that's what's behind research. We are influenced, manipulated by the pharmaceutical industry. We need to wake up. We need to take responsibility for our own health, because unfortunately the model is distorted and this will not change. There is no incentive within the NHS to redress the shortcomings in the diagnostics and treatment of testosterone deficiency. I promise you, no chance. Because just imagine the workload. The NHS would be overrun. Andrology clinics would take hospitals, because the diagnosis of testosterone deficiency is actually quite difficult to make properly and with due diligence, because one should always explore natural ways of increasing your testosterone and explore other pathologies before jumping onto TRT. TRT must be in your best interests. And that is not something the NHS can really address in a 10-minute consultation. My new patient consultations are 60 minutes. They're 90 minutes if we're going to initiate treatment, because I need to go over safe and effective injection technique. So, to be confident that you are acting in the best interest of the patient, 10 minutes is not enough. So it's really unrealistic to expect a GP to go over your ideas, concerns, expectations, the diagnosis, the management. It is not possible. And so they often defer, well, they always defer really, unless you're especially fortunate, but then again, you're not showing due diligence. They refer to the NHS endocrinologists. Now, the NHS endocrinologists are a law unto their own. Some of them subscribe to the BSM guidelines. Some of them do not believe in the diagnosis of testosterone deficiency. They do not believe in functional hypogonadism. So you must have a primary or secondary pathology to receive TRT. You must be below the reference range which has lowered over the last few years, because it now reflects a sick society to receive TRT. So You are on a hiding to nothing. You must take responsibility for your own health. So what got me involved in testosterone replacement therapy? As a medical student, I had dreams and aspirations of being a surgeon. And my house officer year, I was all set up to be on the basic surgical training roster for Sheffield. I had the main man behind me. He was the top boy. But before my interview, I went to God's kitchen. So my interview did not go very well. My headspace was... So yeah, it didn't go very well. What next? So I thought, sod it, I'm off. Went to Australia for a year. Went to dive with great white sharks and travel up the east coast in a combi van with long hair, and yeah, it is what it is. So I came back bored stiff of taking photos of the most beautiful waterfalls and scenery imaginable, because I recognised the need to be productive. My brain needs to be productive, so does yours. So it's all good going on holiday for a couple of weeks, but after 2 weeks, if you're just doing a beach holiday, give me a gun. No, I need to be productive. We need to be productive. So I came back, I actually did a BST in Rotherham, and it was rather uninspiring, because if you want to be a surgeon, you want to be the top boy, and you need to go into it 24/7 and dedicate your life to it. I don't want to work in a DGH, second rate. So if you do get ill, make sure they take you to a teaching hospital, and make sure the top boy does it, not the junior. I always remember doing a hydrocele operation. My urology consultant said to me, "You've seen one of these?" And I said, "Yeah, I've seen one." He says, "Well, I'll be on the end of the phone then." And I literally, the longest operation ever. I did it, but the anaesthetist was like, "Oh, can we go home now?" So yeah, teaching hospitals, just don't get ill is my advice, quite frankly, because it is potluck. Or if you can go private, go private. Just make sure that private hospital's next to an NHS hospital, because if something goes wrong, you want to be transferred over to the NHS hospital. Believe you me. We digress. So yeah, then I went to GP land. I've always been a people person, so GP land suited me. Patient-centered care. Loved it. But, my word, you lot. Inappropriate use of resources and services. Overworked. It was, on a good day, tolerable. On a bad day, 40 odd patients. It was exhausting. You used to have heart sink patients that used to come back to you, that you were really impotent. You couldn't do anything for them, and it was frustrating. And you were there really more as a counsellor, and I used to end the day and not really know what I'd actually achieved. But I liked the whole cradle to grave philosophy. But then the model changed. The model became more about ticking boxes. So what was special about GP land, the doctor-patient relationship, was removed. Have you checked the blood pressure? Have you checked the cholesterol? How are you? That's the important question. So you had to be a jack of all trades and master of none. So disillusioned with that, I disappeared off to the cruise ships and had a life of Riley. But it was like Groundhog Day. Every day is the same. It was a good day, don't get me wrong, but again, need to be productive, need to keep moving on this journey. And the idea of being a ship's doctor for 20 years, again, give me a gun. So prevention was my goal. Use what I knew about nutrition, exercise and lifestyle to effect a change in medicine. So a diploma in personal training, became an insanity instructor, and yeah, it's TRT. It came about watching the UFC. All these guys getting popped for gear and then coming back on these TUEs, therapeutic use exemptions. What the hell is this? So I ended up looking into it. Testosterone, yeah, muscles and sex, yeah. But I really had no idea the impact testosterone has on mental well-being and other physiological processes within the body. I had no idea. It was a revelation, almost like a eureka moment. Boom. This is what you're going to do. So, Lids and I opened up the men's health clinic in a basement room beneath a GP surgery. 2 mornings a week. We were super excited when we had 1 patient each day. Woo. But we were in a really fortunate position to allow it to grow organically. So I kept my out of hours job and then titrated that up and down according to how busy we were. So we've been really fortunate, because the reality is if you'd had to put all your eggs in one basket, you'd have to be pretty damn certain about your model. And we adhere to the BSSM guidelines. So we used to use Nebido. It is the UK licensed drug for TRT. It promises stable levels. Does it deliver stable levels? No. It can, if you microdose, 125 every week or 250 every 2 weeks, depending on your SHBG, because if you have a higher SHBG, you don't necessarily have to have that frequent injection interval, so you could do 2 weeks. But my guys are actually on every week, and that is the way forwards with Nebido. Then we moved on to the American model. So we gained insight through an American forum using enanthate every 3.5 days alongside HCG to maintain fertility. And we've evolved into the practice that we are now. We have people from all over the world come to us. In the last 2 weeks, we've had a guy from Denmark, we've had a guy from the Netherlands, we've got a guy coming over from Lanzarote on Friday. He's bringing gin. Good man. Thank you. Because we do go above and beyond the call of duty for our patients, because we offer a personalised service. This isn't a sales consumer relationship. What do you fancy? We'll just do that. We will always act in your best interest, and we will always go that extra mile to make sure you're happy. So it's fascinating. TRT is a field of medicine that needs somebody to stand tall and break down the barriers. There are other companies and clinics out there that do offer a sales consumer relationship. We're glad they're there, actually, because they have inspired us. They've inspired us to continue on this journey and to make our practice even better. You look at the bad and make it good, and you look at the good and make it better. So competition is good. We don't care about you at all. the reality is there's enough people out there, and we want to legitimize TRT. So we need to remove DECA, Anavar, peptides, because we're having enough trouble having NHS endocrinologists accept the legitimacy of actual just testosterone and HCG. So HCG, you can't have HCG unless you come off testosterone. Testosterone causes suppression of your hypothalamus and pituitary. So if you want to retain fertility on testosterone replacement therapy, you have HCG alongside testosterone. But you guys know I like the philosophy of maintaining function and optimizing testosterone. That makes sense. So, common sense medicine. I am not the brightest man in the world. I'm not an academic. We have Joseph Earnshaw, sorry. He is our medical researcher. And so we give him tasks. We always come to the same conclusion. He comes at it from a very different angle to me. I come from the holistic kind of patient-centered care. I'm able to empathize, contextualize quite well. Lots of academics aren't. We're lucky to have found Joseph because he can. So there are some world-renowned doctors who produce these guidelines, but they can't conceptualize these issues, and it's disappointing. So we will take things forwards and offer gold standard, baby.